Good day. So today we're gonna discuss the beta-adrenoceptors blocking drugs class 2. Under this beta-adrenoceptor blocking drugs, we are going to discuss 3 drugs under this, which are propranolol, esmolol, and sotalol. So let's start with propranolol. Propranolol is an anti-arrhythmic drug wherein the properties is by virtue of their beta receptor blocking action and direct membrane effects. It also has selectivity for cardiac beta 1 receptors and have intrinsic sympathomimetic activities. And it also have a marked direct membrane effects, wherein it prolong the cardiac action potential. Although beta blockers are fairly well tolerated, their efficacy for suppression of ventricular ectopic depolarizations is lower than of the sodium channel blockers. So, however, there is a good evidence that these agents can prevent recurrent infraction and sudden death in patients recovering from acute myocardial infarction.
Let's move on to esmolol. Esmolol is a short-acting beta blocker used primarily as an anti-arrhythmic drug for intraoperative and other acute arrhythmias. So esmolol is an intravenous cardioselective beta 1 adrenergic antagonist. It has a rapid onset but short duration of action without causing significant intrinsic sympathomimetic or membrane stabilizing activities at recommended therapeutic dose. So it works by blocking the beta adrenergic receptors in the heart, which leads to decreased force and rate of heart contractions. So esmolol prevents the action of 2 naturally occurring substances. This was mentioned before, which is the epinephrine and norepinephrine. So, esmolol is also used in various settings, including urgent care and perioperatively and postoperatively. And it is also indicated in sinus tachycardia, where a rapid rate requires intervention secondary to other comorbidities. Esmolol is further FDA approved for tachycardia and hypertension induced by intubation. So let's move on to sotalol. Sotalol is a non-selective beta-blocking drug that prolongs the action potential. So it is known as the first of the class 3 anti-arrhythmic drug. So sotalol was first approved as an oral tablet. The race mixture of sotalol is currently formulated as tablet, oral solution, and intravenous injection. So it is indicated for life-threatening ventricular arrhythmias, and it maintains normal sinus rhythm in atrial fibrillation or flutter. So again, we just discussed the class 2 beta-adrenoceptor blocking drugs, which are propranolol, esmolol, and sotalol. Let's move on to the drugs that prolong effective refractory period by prolonging the action potential, which is the class 3 drugs. So these drugs prolong action potentials, usually by blocking potassium channels in cardiac muscles or by enhancing inward current. For instance, through the sodium channel. So this action potential prolongation by most of these drugs exhibit the undesirable property of reverse use dependence. So the action potential prolongation is least marked as fast rates, wherein it is actually desirable, and most marked at slow rates, where it can contribute to the risk of having Tertiaris de points. I'm sorry if I butchered that. Although most drugs in the class cause QT prolongation, there is a considerable variability among drugs in their pro-arrhythmic tendencies to cause Torsades de points despite significant QT interval prolongation. Recent studies suggest that excessive QT prolongation alone may not be the best predictor of drug-induced Torsades de points. While other important factors in addition to QT prolongation includes action potential, stability, and development of a triangular shape, or also known as triangulation, reverse use dependence, and dispersion of repolarization time across the ventricles. So now that you know what the class 3 or drugs that prolong effective refractory period by prolonging the action potential is, we can now move on to the specific drugs that we're going to discuss today. So let's first discuss amiodarone. So in the US, amiodarone is approved for oral and intravenous use in order to treat serious ventricular arrhythmias. However, the drug is also highly effective in the treatment of supraventricular arrhythmias such as atrial fibrillation. Due to the broad spectrum of antiarrhythmic action, it is very extensively used for a wide variety of arrhythmias. So now that we know those informations about it, let's move on to the cardiac effects of amiodarone. So amiodarone is markedly prolongs the action potential duration. So the QT interval on the ECG. So ECG is the electrocardiogram by blockade of IKR. Well, during chronic administration, IKS is also blocked. So the action potential duration is prolonged uniformly over a wide range of heart rates. That is, the drug does not have reverse use dependent action. So despite being a class 3 drug or class 3 agent, amiodarone also significantly blocks inactivated sodium channels. So its action potential prolonging action reinforces this effect. Also, amiodarone has a weak adrenergic and calcium channel blocking actions. Consequences to these actions include the slowing of the heart rate and the AV node conduction. Due to the broad spectrum of actions, this can account to its very high or relatively high efficacy and low incidence of Torsades de points, despite the significant QT interval prolongation. So, on its extracardiac effects, amiodarone causes peripheral vasodilation. This action is prominent after intravenous administration and may be related to the action of the vehicle. So as you can see in the image, so this is the normal blood vessel, and on the right side is the vasodilation. It is the dilated blood vessel wherein there's a decrease in blood pressure and increased transport of oxygen. So now that you've heard the cardiac and extra cardiac effects, why not let's move on to toxicity. So amiodarone may produce symptomatic bradycardia and heart block in patients with pre-existing sinus or AV node disease. So this drug accumulates in many tissues, including the heart. So it has 10 to 50 times more so than in plasma. I was referring to the heart, okay? So the lung, liver, and the skin also, the drug also accumulates in these tissues. So another toxic effect of amiodarone is the dose-related pulmonary toxicity, which is its most important adverse effect. So even on a low dose of 200 milligrams per D or less, it can cause pulmonary fibrosis. So it can be observed in 1% of the patients that take this drug. So another toxic effect of this is abnormal liver function and hypersensitivity hepatitis. So this may develop when the patient is taking this amiodarone treatment. So they have to always have a liver function test. So it should be monitored regularly. Well, other than this toxic effects, there are also toxic effects that can be seen by the naked eye that doesn't require tests. So, for instance, the skin deposits can have a photodermatitis and have a gray-blue skin discoloration in sun-exposed areas. So, as you can see in the image, those are the gray-blue skin discoloration. So, for instance, the malar regions. So let's proceed to the eyes. After a few weeks of treatment, there will be a asymptomatic corneal microdeposits, which are present in virtually all patients treated with amiodarone. So halos develop in their peripheral visual fields. Well, actually, drug discontinuation is not usually required because it is rare when an optic neuritis may proceed to blindness. So why does this happen? So that's a good question. Amiodarone blocks the peripheral conversion of thyroxine or T4 to triiodothyronine or T3. Another notable toxic effect could be hypothyroidism or hyperthyroidism. So the thyroid function should always be evaluated before initiating treatment. And also, as we go through the treatment, we should also monitor it periodically. As you notice, there's actually a lot of toxic effects or toxicity, which basically virtually affects every organ system. So that's why we should always reevaluate whether there's a new symptom that a patient has, including arrhythmia aggravation. Now that we finished the toxicity of the drug, let's now move on to the pharmacokinetics of the drug. So, amiodarone is variably absorbed with a bioavailability of 35% to 65%. So, it actually undergoes hepatic metabolism. And the major metabolite is desethylamidodarone, which is bioactive. Also, the elimination of the half-life is complex, with the rapid component of 3 to 10 days, for the 50% of the drug, and the slower component of several weeks. After discontinuation of the drug, the effects are maintained for 1 to 3 months, wherein the measurable tissue levels can be observed up to a year after discontinuation. For the dose recommended or suggested, this was included in the book, it was a loading dose or a total loading dose of 10 grams, which is achieved using 0.8 to 1.2 grams daily doses, and then a maintenance dose of 200 to 400 milligrams daily. Just please take note of milligrams and the grams to avoid any issue. In order to achieve the pharmacologic effect rapidly, we can use the intravenous loading. So the QT prolonging effect is modest with this route of administration, whereas the bradycardia and AV block may be significant. So please note that amiodarone has many important drug interactions, and all medications should be reviewed when this drug is initiated and when the dose is adjusted, because there might be an effect, positive, negative, which should be noted. Amiodarone is a substrate for liver cytochrome, which is CYP3A4, and its levels are increased by drugs that inhibit this enzyme. For instance, the histamine H2 blocker, cimetidine. Drugs that induce CYP3A4 is, for instance, rifampin. So there's a decrease in amiodarone concentration when it is co-administered. So amiodarone inhibits several cytochrome P450 or P450 enzymes and may result in high levels of many drugs including statins, digoxin, warfarin. The dose of warfarin should be reduced by 1/3 to 1/2 following initiation of amiodarone, and prothrombin times should be closely monitored. So this is the one I mentioned earlier, that when you're taking amiodarone with another drug, they should consider the dose and should adjust each drug accordingly. So in order to effectively maintain the normal sinus rhythm in patients with atrial fibrillation, they use a therapeutic use, low doses of 100 to 200 milligram per D. Now that we have finished amiodarone, let's now move on to dronedarone. So dronedarone is a structural analog of amiodarone, in which the iodine atoms have been removed from the phenyl ring and a metane-sulfonyl group has been added to the benzofuran ring. So this design was actually intended in order to eliminate action of the parent drug on the thyroxine metabolism and also to modify the half-life of the drug. So on this drug, there is no thyroid dysfunction or pulmonary toxicity, which wasn't reported in this short-term studies that was conducted on this drug. However, there's a liver toxicity, including 2 severe cases requiring liver transplantation, and like amiodarone, dronedarone has multi-channel actions, including the blocking of IKR, IKS, ICA, and INA. It also has a beta-adrenergic blocking action. So this drug has a half-life of 24 hours and can be administered twice a day at a fixed dose of 400 milligram. So dronedarone absorption actually increases 2-fold or even 3-fold when taken with food. So with this information, it should be communicated to the patient when we are giving the dosing instructions or when we are having a patient consultation. Dronedarone is both a substrate and an inhibitor of CY3A4 and should not be co-administered with potential inhibitors of this enzyme, such as azole and similar antifungal agents and protease inhibitors. Dronedarone restores sinus rhythm in a small percentage of patients, which is lower than 15%, with atrial fibrillation. It produces a 10 to 15 beats per minute reduction of the ventricular rate compared to the placebo. The drug also carries a black box warning against its use in acute decompensated or advanced heart failure or class 4 heart failure. So now let's move on to the third drug in this classification. So the next drug is sotalol. Sotalol has both beta-adrenergic receptor blocking or class 2 and action potential prolonging, which is class 3 actions. The drug is formulated as a race mixture of D and L sotalol, and all the beta-adrenergic blocking activity resides in the L isomer, and at the D and L isomer shares action potential prolonging effects. So the beta-adrenergic blocking action is not cardioselective and is maximal at doses below those required for action potential prolongation. Sotalol is well absorbed orally with bioavailability of nearly 100%. It is not metabolized in the liver and is not bound in plasma proteins. In order to excrete this, it is through the kidneys in unchanged form with a half-life of approximately 12 hours. Because of its relatively simple pharmacokinetics, sotalol exhibit few direct drug interactions. One of the most significant cardiac adverse effect is an extension of its pharmacologic action, which is a dose-related incidence of Mercedes de points that approaches 6% of the highest recommended dose or daily dose. So the patients with overt heart failure may experience further depression of left ventricular function during treatment with sotalol. Sotalol is approved for the treatment of life-threatening ventricular arrhythmias and the maintenance of sinus rhythm in patients with atrial fibrillation. It is also approved for treatment of supraventricular and ventricular arrhythmias in the pediatric age group. Sotalol decreases the threshold for cardiac defibrillation. On the next video, they will also discuss the other drugs that is included in class 3 or the drugs that prolong effective refractory period by prolonging the action potential. So I hope to see you there on the next video. Thank you!